Aloha, everyone. I'm so excited to have this group of experts with us here today, notably with over 100 years of experience and expertise in nursing with preponderance in critical care, where vigilant infection prevention and diligent quality of care is always required for saving lives. We're going to talk to you about eliminating CLABSI today and how your third hand can safely no longer infect your patients. Please welcome my esteemed colleagues, Kathleen Volman and Naomi Ragsdale, and I am Cindy Cadwell. Next slide. We are, as nurses, quite frequently the last line of protection against many healthcare-associated events, and we know this very well. Our goal today is to provide you with the latest data you will need to take back to your units so that you can modify your practice and help eliminate healthcare-associated infections by implementing new best practices, particularly those specific to the latest CDC guidance regarding stethoscope hygiene. The agenda we have planned for you today will provide you with that evidence-based data on stethoscope hygiene and a case study to exemplify how you could improve your own practice. We hope this is info you will be able to take back to your teams to impact your overall healthcare-associated infection incidents. Our contact information will be available for you at the end of the presentation. Kathleen, can you tell us about this problem?
Absolutely. And I think it's important whenever you're working on something new or different in the environment is to absolutely understand the why. Why are we doing it? Why do we need to change? And that why really focuses around avoidable injury, and that is healthcare acquired infections. So it is an avoidable adverse event, and it is associated with significant mortality rate in the United States, about 100,000 people a year. That's a lot when you think about it. One of the ways that I make it more real for me is, and considering what has been in the news recently, this is comparable, the number of people dying to a crash of a large 747 airplane falling out of the sky each day with no survivors. That's really significant. So when we look at overall estimated costs, so that's the cost in human life, what is the cost financially to our healthcare systems of these avoidable hospital-acquired infections? You're looking at anywhere between $28 and $33 billion a year. Because of increase in length of stay, the morbidity, mortality that I talked with you about, and overall increased costs. And you can look specifically at the major HAIs that we see in our hospital, catheter-associated urinary traction infection is about $14,000, and these are non-reimbursable. CLABSI is close to 50,000, same as ventilator-associated pneumonia, and surgical site infection is about 29,000. When you put that together as I've got to pay for this care when it happens, the other component that comes in is the value-based purchasing program and hospital-acquired conditions, which also provide penalties for when these infections occur. So it absolutely makes a difference looking at those factors that can contribute to transmission of microorganisms in our environment and cause potential harm for our patients.
Thank you, Kathleen, for exposing those disturbing stats. I think we all recognize the why here is critical, and we've put a lot of effort into trying to improve things. And it's interesting to me, as far back as 2014, there were publications already pointing out to the fact that pathogens exist on the clinician's third hand, the stethoscope. And nurses play such an important role in infection prevention as we frequently use our third hand to assess our patients. It's notable that finally the CDC has acknowledged this and updated its guidelines. In this new CDC guidance, it elevates the stethoscope to a transmission via touch item that is in the same category as the hands. So the third hand makes much more sense to us considering those new guidelines. It's almost unbelievable that the previous guidance from 2008 basically said to disinfect the stethoscope when visibly soiled or once a week. Fortunately, we do learn and improve, and the benefit from innovations of technology are here to help us. And we've learned a lot with technology over the years as well. Do you guys remember all of the effort put into hand hygiene as we recognize this as the number one source of contamination between patients? The stethoscope now needs to be looked at as that third hand for its same cross-contamination hazard. In this 2021 call to action publication, recommendations were made for the CDC to recognize the spread of pathogens via the third hand, as it is a clear and present danger. And finally, as I said, they've come to that conclusion themselves as well. So now that they propose the same consideration as hand hygiene, that is between every patient encounter to ensure no cross-contamination, it's incumbent upon us to look at how we can basically improve our care by accommodating this. As depicted in this publication by Peacock et al., it's the new normal for the clinician's third hand is actual stethoscope hygiene between each patient. It's really important to note that we don't have the ability to just wait until we are forced to comply with this. We have the knowledge, we are aware of the new guidelines and the data supporting why we need to make these changes in our stethoscope hygiene. And I want to shout out some kudos to AORN, our surgical sterility and aseptic environment experts. They've already made headway in updating their policies. I believe it's our duty as critical care patient advocates to expose the old, flawed systems that we have in place and apply better methods to achieve the outcomes that the patients expect from us. And that is basically no hospital-acquired or healthcare-acquired infections. Kathleen, could you please educate us on the pathogenesis of the third hand?
Absolutely, Cindy. You know, it's amazing that the pathogens that we paid so much attention to on the hand are the exact same or very close, about 80%, 85% identical to those that are contaminating our stethoscope. So the concept that we didn't even pay attention to this when we put so much emphasis and focus on hand hygiene makes me a little a little crazy. It it the pathogens are very diverse. They come in contact as frequently and move from patient to patient as our hands do. The stethoscope touching the chest, what's in the chest area, lines, tubes, and it is a vector, which is why it's called the third hand. And we need to think of it in partnership. If we're going to pay attention to hand hygiene, which I know every single one of your places is doing, then we need to pay attention to stethoscope hygiene. And so this was a study looking at a viral DNA surrogate marker to identify routes of transmission of healthcare associated pathogens, because the outcome of us not doing the right thing is our patients likely going to be harmed. So these were known MRSA infected patients, and they tested the gloved hands, stethoscope diaphragm, clothing touched by the patient, and then they did a culture of all of these. And what they found is a transmission of these microorganisms 52% of the time on the gloved hand, 48% on the clothing, and the stethoscope diaphragm was right up there at 40%. And sometimes we believe, I know in our isolation rooms, we tend to use the disposable stethoscope and find that as a solution. But is it really a solution? In a large study that was done to be able to evaluate diagnostic errors that may occur with a regular stethoscope versus a disposable stethoscope, you're looking at 11% of the time errors are missed. Do you want to miss a murmur? Do you want to miss rails in the lung? No. I don't think we want to do that for our patients. So I don't believe that this is the solution. And even if you do believe it's the solution, I'm going to gross you out here with the concept of the shared, because it is a shared stethoscope in those isolation rooms, about the earpieces themselves. So 78 dedicated stethoscope earpieces were cultured, and 17% were contaminated with potentially pathogenic bacteria. Take a look at this. Are these familiar to you, the bugs? MRSA, Acinetobacter, Pseudomonas, E. coli. None were contaminated with the same pathogen for which the patient was prescribed contact precautions, so it's coming from other sources. And so this is a wonderful diagram by our colleagues at AORN, putting the picture all together for you, that one, the diaphragm of the stethoscope and the earpieces are contaminated. So the disposable doesn't work. You need to have your own stethoscope. That bacteria sits there for anywhere between 6 to 18 hours. So we need to be able to make sure we're cleaning in between each patient use. Most of the stethoscopes, as I stated, between 70 and 85% of them are contaminated after the physical examination is performed. And those bugs that are recovered, Staph aureus, gram-negative rods, and Enterococcus species. So really, hand hygiene and stethoscope cleaning need to be partnered together to get the maximum benefit of reducing transmission in between caring for patients. So I am going to hand it back to Sandy so she can talk to you about the two dirty little secrets that happen.
Thank you, Kathleen. I really appreciate you bringing up all those points. You know, as a nurse practitioner, the use of my stethoscope to diagnose is critical. And those, I call them toy stethoscopes, are really ineffective. You can't use them to really diagnose. And that became really evident to many of us during COVID when we didn't have the ability to bring x-rays in and additional tools. So it is really important to have a good quality stethoscope that you can use that doesn't carry bugs from your predecessor. So getting into the actual quality of how frequently we actually do provide care, stethoscope hygiene. I think we're all well aware when we started doing the hand hygiene observations of how absolutely awful it was. So Kathleen, I just want to ask you, in your experience, what would you say is the estimate of the percent of critical care nurses that are aware of the stethoscope hygiene problem as it relates to CLABSI in particular?
Well, first off, I'll just say across the board, people aren't thinking about it. We have to change that and change it collectively for all transmission. But because the central lines are on the chest, and that's exactly where the stethoscope goes for heart and lung assessment, there is an association. And so I would say that we really need to ramp up the education and the understanding of the significance of transmission on the stethoscope.
Absolutely. Thank you. I don't know that I've seen very many critical care teams doing that just yet, but we are fortunate enough to have Naomi Ragsdale will be showing us a case study where they actually did do that. So let me just move to this additional information. We know that when we found the hand hygiene data was just shocking, and we had to put in a lot of implementation of various pathways in order to get people to do the right thing. I always like to bring up the fact that we are all human and we are going to make errors. It is a fact. And as a quality expert, that is 101. We know that. So what it is our job to do is put as many bumps in place to prevent you from doing the wrong thing and help guide you to do the right thing. And the way to intentionally provide the best care is for us to make sure that we are utilizing all the reminders and technology, et cetera, that is available to enhance that care. The findings with stethoscope hygiene are just way worse than hands. So if you thought it was bad with hands, it's way worse. It's just like Kathleen mentioned, nobody's paying attention to it. There's a couple well-designed studies that show us stethoscope hygiene between patients, that means the third hand, was measured as low as 4%. 4%. That's just way beyond it, how bad it was with hand hygiene. And to make matters worse, as Kathleen's already pointed out, it's the same pathogens. So in these studies, even though the providers in these ERs demonstrated that they were doing hand hygiene, which was not fantastic, by the way, it was significantly better than what they were doing with the stethoscope. So I think it's really important for us to recognize we have not been thinking of the stethoscope as the third hand. We have not even been addressing it. I know in my practice years and years ago as a critical care nurse, it was not a concept that we even thought about. So clearly we need to improve hand hygiene, but we also need to ingrain that the stethoscope is that third hand. And that concept, I think, is going to be vital to our improvement of practice. So to make matters worse, if cleaning between patients with alcohol does not even fully eliminate the pathogens, as demonstrated in these cultures in these particular studies, and we already know alcohol is inadequate in effectively eliminating all pathogens anyway. So in my mind, for all of the effort that we're putting forth to just clean the stethoscope with alcohol in between patients, for that to be ineffective, it's truly an inefficient use of our time and also one that could result in a deadly outcome regardless. I think one could easily argue that barriers for the stethoscope diaphragm should be used and to ensure complete prevention of contamination and against all pathogens, not just those that are susceptible to alcohol. And these studies talk a bit about that. So I think that these are also valuable resources for you to take back to your organizations to effectively make the case for why you might need to make some changes in your practice. Okay, I'm sure all of you are familiar with the Institute of Medicine's Quality Improvement Framework, and many of you may be old enough to remember the original paper that came out to say to err is human. So I would say that we do know at this point, we've learned a lot over the last 20 plus years, and I think it's a really good framework to put in place to understand how you can go ahead and make changes at your institution. And, you know, just like hand hygiene, we need to create processes by which the nurse is reminded to do the right thing each time, every time, as they walk through the door to the patient's room, so that they never stop doing the right process. And once it becomes standardized, you do have much greater impact because it becomes a routine process. What we are fortunate now to have is that we've had innovative technology in the past that has brought us to this point. We have new innovative technology for the stethoscope hygiene as well that seems to be the answer in this case. And I'd like now for Naomi Ragsdale to show us how they did just that.
Hi, thank you so much. Yes, I'm Naomi Ragsdale, and I've been in nursing for almost 30 years now, and infection prevention for 16. And I'm excited to just share our journey with stethoscope hygiene. You can move to the next slide. Thank you. So just a quick disclaimer. This presentation and materials given in conjunction with a non-government entity do not constitute an endorsement or recommendation of any product, service, or enterprise by the Department of Veteran Affairs or any of its employees. So, like I said, I'm going to walk you through our journey with stethoscope hygiene, a little bit about the Memphis VA. It's a 126-bed teaching facility in the heart of Memphis. We provide healthcare services to more than 196,000 veterans in a 53 county area of Western Tennessee, Northern Mississippi, and Arkansas. So that's just a little bit about the VA. So we need to just rewind back to 2018, back when I was still fresh in infection prevention at the VA. I'd only been there a little less than a year. We were already facing a major challenge we'd had a huge increase in our central line associated bloodstream infections in our ICU. At that time, we had a 28-bed ICU that was split between medical and surgical units. And in less than a year's time, we had 6 central line infections, 3 in our medical unit and 3 in our surgical unit. Not exactly what you'd want, right? And this is my first year there, and a little panic alarm going off. Obviously, our director was alarmed, and it wasn't long before leadership's eyes were really on us, really like focusing in on what is going on in our ICU. So, of course, we did what any determined team would do. We rolled up our sleeves, dug in, scrutinized everything from basic central line maintenance, and then just focused on the basics of infection prevention. Hand hygiene always, that's just a number one priority. And then cleaning of equipment between patients. And that's when we spotted the stethoscopes. It turns out, as we mentioned in the prior, presenters mentioned that not many people are cleaning between patients. They are just not doing the proper hygiene for stethoscopes. And in our observations, and we're observing, they know we're infection prevention, and they know who we are, and they're trying to be on their best behavior. And even then, over half of the staff were not cleaning between the patients. So when we reported this to leadership, they had a very strong and swift reaction. They pulled the plug on all personal stethoscopes and switched to disposable stethoscopes dedicated to each room. As you can imagine, these toy stethoscopes were not a big hit. It didn't sit well. The backlash was pretty swift, and leadership had to backtrack and reverse that decision, obviously. But what this did, this opened the door to something new. It was, the first time we had a real conversation about stethoscope hygiene. So the following year, we decided to experiment with disposable plastic stethoscope covers. We trialed those, like I said, in 2019, and they sounded great in theory, but in actuality, they were honestly a real pain. They took time to put on, and in our observation, we really felt like they might be causing even more contamination when being removed. They're just real cumbersome and just kind of hard to deal with. So we did not implement because we did not have any good feedback on them. So we're, back to square one. And then boom, COVID hit, and suddenly everything shifted. I had to include some humor here because at the time there was nothing funny about our situation. As you are all aware in healthcare, it was a very, very tough time. So, this is our testing tent. We're running testing tents, we dedicated COVID units. And in the middle of all this, our CLABSI rates had actually started to drop. But as COVID wore on, unfortunately, our infection numbers crept back up. Infection prevention, it feels like a giant game of whack-a-mole. You knock down one infection and then another one pops up. And in this case, of course, the pandemic it affected so many operations within our hospital. It's not surprising that the CLABSI rate would increase. So finally, in March of 2022, when we felt like we had a better grasp on COVID, we refocused on CLABSIs with new energy. We took a bundled approach. We standardized our dressing kits. So at the time, we were using different dressing kits for dialysis catheters and then all of our other central lines. So we standardized the kits. We rounded daily, including weekends. So infection prevention would come in on the weekends to round. Retrained staff. We had them demonstrate their technique with, dressing changes and care of the central line. And honestly, it was all over the place. So retraining was absolutely necessary. And then we eventually circled back to the basics of infection prevention. Of course, like I mentioned before, hand hygiene, and you guessed it, stethoscope hygiene. So we're back there. So, and it was perfect timing too, because in 2023, we were introduced to a diaphragm cover for stethoscopes. And so that became the last part of our bundled approach. And this wasn't just any cover. It was, touch-free, very, very simple to use, easy to use. It didn't compromise any of the sound quality at all. And we just all thought that this is something that we can work with. The idea, I think, Kathleen, you mentioned the idea of decreasing contamination around the central lines, particularly those that are located, in the subclavian area and the IJ area. And so, we'd had actually several infections with our permacasts, and they're generally located in that area. And so we just really could wrap our heads around this. And we had great feedback from clinicians as well. So we were, an additional benefit, we were able to phase out many of the disposable stethoscopes. So here we are today, very, very thrilled with the results. Since implementation of the entire bundle in August of 2023, we've only had one central line infection and since that time, and so that's 0 in 10 months, and we're still moving forward in that direction. And as mentioned previously, the stethoscopes they really are like your third hand, and why it was such an added benefit to implement this system in our bundled approach to decreasing the central line infections. We're just very, very, very pleased with it.
Thank you, Naomi. I really am impressed with what you were able to do. And as a quality expert, I just want to say that the methods that you went through were just right spot on. Nothing like going in and doing an observation. It's quality 101. You have to identify the problem and, going to the right approach. I also like the fact that you follow the issues, that you're having an increase in numbers, and that you had support from your leadership. Did you have much issues with the leadership support, or were they just profoundly interested in you getting those CLABSI numbers down?
Well, we did not have a lot of issues with leadership support. I will say that we honed in on the mortality associated with CLABSI, as well as, the added cost and length of stay. And when you put those numbers, so we put those numbers in line with how many infections we'd had, and it really, it just hammered in that we needed to make some changes.
Excellent. It's always good to make the case and use evidence to support that. Speaking of evidence, what made you end up selecting the disc cover system? How did you find it? How did it come into even being aware of that technology? Well,
we were looking for something for stethoscope hygiene, and we've done, a literature search with this bundled approach with stethoscope hygiene involved, and we did not have any results. And so we, just thought that we needed to include that in our bundle, and we were introduced to this diaphragm cover, and it was just the last perfect piece that we really needed.
Excellent. I like your process of evaluation, using the literature search, testing and trialing things that may work to help you, and then ultimately identifying something that hits the nail on the head. Some of the things that become really important in quality improvement are making sure that it works with the workflow that the staff are doing. If it doesn't work with the workflow, it's not going to happen. We know that. And I also like the fact that you were looking at standardizing. It's always useful to make sure that everybody's doing the same thing the same way, and providing that kind of routine, because once it becomes routine, then we end up having much more success in our results. Mm-hmm. So great job doing that. Let's go ahead and talk a little bit more about that. Could you move to the next slide, please?
Thank you. Many of you may remember that picture. Go ahead and put that slide back up, of scrub the hub, alcohol wipe. I never had it in my pocket. It was across the room. And we were not good at this. And it was literally technology that helped us see that we had a way to ensure, even though we still scrub, that I've got some protection, some alcohol-based protection on my hub now of my IV. And this played a role in completely elevating to best practice. So that takes us to, how do we get there to best practice for stethoscope hygiene. And Naomi talked about it. This is the disc cover that they implemented. You can see it's completely touch-free, very easy, going right into the workflow. You can put it right next to your glove boxes. It's easy to use. It improves or has neutral impact on the workflow. You can see 100% you get to use your own stethoscope, and it is protected. So it is improving patient safety, and you can connect it, as I said, seamlessly with hygiene protocols by either putting it near the alcohol dispenser or near the gloves as a way to make it easy, as Cindy talked about, for people to do the right thing. So, um, key finding when this was actually tested to look at, did it protect the diaphragm from contamination? And it basically was, when they tested it in a study, it was 100% culture negative when the disc covers were used. So we know it's doing the job we need it to do. And it also makes it easy for people to do the right thing in reducing those transmissions. I take it off when I'm done. I walk out the room, I go see my next patient. I put another one on when I'm doing my physical exam. So it's going to be just part of the routine flow of practice. So, as you can tell, I think we've put this together throughout the entire presentation, is a partnership clearly between hand hygiene and stethoscope hygiene, with the stethoscope being the third hand. And so you want to be able to link your policies and procedures so that they are interwoven for the staff. And that's exactly what we've provided for you. And that is an update policy and procedure of what the new standard of care is. And it's authored by nurse specialists in critical care, quality, and infection control. It's a template so that you don't have to reinvent the wheel. And it should be strongly linked as part of your hygiene policy and procedure, but strongly linked to hand hygiene procedure. And it goes through all the science that is needed to support in any policy and procedure you build, as well as the actual practice. So having that updated policy and procedure and having stethoscope hygiene is critical to achieving best practice in our clinical environment to reduce transmission and work at preventing healthcare acquired infections. So, Cindy, my understanding, whenever a new project or a new quality improvement enters into the environment, there's always somebody raising their hand going, it's going to cost us so much money. How do we show that balance of return on investment?
I'm so glad you brought that up, Kathleen, because that is absolutely the case many, many, many times. And, there's no doubt that doing the third hand hygiene is the right thing to do now that we are fully aware of it. But getting to yes and helping to actually move the process forward does require a little bit of a analysis of that cost of stethoscope hygiene versus the cost of hygiene failure. Here's the good news. We have some data here that is going to be accessible to you as well, to go ahead and take that back to your healthcare institutions. It was nice that Naomi's organization was wholeheartedly behind it. I'm grateful that you found that, Naomi. I can tell you that it's been my experience that is not always the case. One of the number one things of looking at the cost analysis is, what is the cost of doing the right thing versus not doing the right thing? In this slide, we can see that the study looks at the cost impact of conducting stethoscope hygiene as recommended with a 60 seconds of alcohol cleansing between patients. We've already talked about the fact that this is ineffective because alcohol doesn't clean everything, or will not kill all of the organisms that are of interest, besides the fact that it's just not 100% effective. So when we have this kind of limited efficacy and the cost in provider time is just extremely high, knowing that the number one cost in facilities is the nurses, the people that are providing the care, it's just not effective to be using something that doesn't work well, that the nurses aren't doing anyway, and basically costs a lot of time and energy on their part. So let's face it, it's just not going to happen this way doing the alcohol wipes. So you need to find a workflow friendly, and the facility is much more likely to go ahead and want to move forward with that. So this is always a very good piece of data to use to start off. Another piece that I think is really important for you to understand, for all of us to understand, is that with Press Ganey looking at the patient's perceptions, a new patient perception has to do with how well we are providing a clean environment for them. The patients became particularly aware of this during COVID. Needless to say, they were prior to that all just looking more at the environment as clean. This has become very, very important to patients. And the reason that it's not just important to patients, but important to us is because Press Ganey surveys and the patient satisfaction experience actually is addressed in the revenue streams for your facility. Poor numbers equal poor reimbursement. And this comes from CMS, Medicare, Medicaid, which happens to be the number one payer for most facilities. So it's really important to your administration that the patients get to see you doing the right thing. And how wonderful for the patient to be able to see you putting that stethoscope cover on your stethoscope before you touch them or their loved one. I can tell you that one of the things that we did with hand hygiene was mention as you're washing your hands that we are washing our hands to protect you from any kind of pathogens or any kind of bacteria transmission. It makes the patient aware, and it helps improve their overall memory of when they're going to go ahead and put down that score for you. So it is very important. It affects, patient perception as well as your reimbursement. I will say this also, it's, the legal cost associated with healthcare acquired conditions, especially infections, is ridiculous. And as a previous patient safety officer for a large healthcare system, one of my responsibilities included doing the in-depth root cause analysis and reviews with our legal team of cases that went wrong. The numbers associated with the liability of even just one case is astronomical. And as Kathleen pointed out earlier, when you combine all of these numbers up to the top number, it is huge and huge impact on our healthcare systems. Because of the fact that we not only want to reduce the amount of healthcare acquired conditions because it affects reimbursement as well as liability and cost for the patient, meaning morbidity, mortality, length of stay, et cetera, is also really important from a reputation standpoint. The last thing on earth your facility wants is that newspaper ad or that newspaper article talking about the bad things that happened at your facility. And it's not just in healthcare journals nowadays, it's also in the legal journals. So we are at risk if we don't do the right thing. And if with all of the CDC guidelines coming out and all of this data that we now have available to us, it's incumbent upon us to just start implementing the right kind of stethoscope hygiene ASAP. Okay, so again, more information for you to share. So the good news is we are finally at a point where we don't have to compromise our time, we don't have to compromise our patient, nor our integrity. And it is harmful to our staff to know that they are not able to do the right thing all the time, every time. And now we have the ability to use the latest in technology for stethoscope diaphragm barriers to eliminate that problem. And the data is there. It's demonstrated to be useful. It's demonstrated to completely eliminate the transmission of pathogens from the stethoscope to the patient. This is the third-hand technology that we needed, and it's now available. So we have to at least start doing that with our patients in order to prevent these healthcare associated infections from the transmission from our stethoscopes. They are a vital device that we must have in order to safely assess our patients. Now we can do that safely without transmitting infection. In conclusion, I think it's really important for us, again, to recognize that we need to voice our needs to ensure our patient safety to our administrators. In these conclusions, I think probably the most important one down at the bottom are the nursing-led quality improvement projects can effectively improve patient safety and reduce pathogen transmission. It starts with you at the bedside. They may have the information that the infections are higher, but at the end of the day, they don't know exactly what little issues are going wrong. And unless you have very astute infection preventionists, such as Naomi, coming in and actually observing and saying, wow, they're not washing those stethoscopes, you're not going to necessarily know. The nurses will be the ones that are quite frequently aware of what's going on. And now that we have novel barriers, diaphragm barriers available, I want you to make sure that as the bedside nurses, you recognize how important you are. And I hope that we've been able to provide you with all the tools you need to help you do just that. So I have a couple questions for Kathleen and for Naomi. Number one, Kathleen, how important do you think implementation of a stethoscope hygiene policy and procedure is to any and all areas of clinical care, such as this one that we collaborated on?
Well, for me, you have to have the structure. You know, it follows the quality improvement of structure, process, outcome. The structure is the policy and procedure. The structure is also the equipment. The process then are the steps that the clinician takes to reduce variation and prevent harm. And the outcome is the reduction in transmission and the reduction in infections. So in most of every clinical practice that I changed, it always started with a policy and procedure.
It's just a requirement.
Yep.
And I will say, you know, when we educate our staff, a lot of staff do request to see where's the SOP, where's the policy behind this, you know, and it's just nice to have that.
I'm glad you brought that up, Naomi, because that was going to be my next question to you. Is basically you've gone through the processes, but then when it gets down to it, the staff want to have a PMP. Did you guys have to craft your own, or did you have some template available to you, such as this one that we've collaborated on?
We had a template. Well, we had assistance from, yes. So thankfully.
So
well, I will tell you,
Can we
I
pause?
wrote a lot of my policy and procedures. They're not fun. So if you have some structure where I just have to plug in and make it easy for me to be able to get going on this, I am in heaven.
Right. That was my point, because everywhere you go, there is a template of sorts in which to incorporate the data that you want for the new policy and procedure. This particular template is basically a policy and procedure specific to stethoscope hygiene for the ease of use for people that are making those changes. So I think it's really nice to know that this is also available to team members. So when you're going back to your team and they're having to put together all of these pieces, which basically is a lot of work and a headache, as Kathleen mentioned, and most people don't enjoy it. I'm sure that wasn't the top thing that you couldn't wait to do on your list either, Naomi, right? So it's nice to have that kind of template available. And I want to end with, if you can move to the last slide, and just thank you all for your valuable time, and say to our colleagues in the field that our contact information is listed here. We really hope to hear from you on your experiences in reducing healthcare associated infections, especially by implementing the new hygiene practices as suggested by the CDC for that third hand. And lastly, I want to thank a Stethoscope for sponsoring this vital education program and helping us all improve our patient safety practices and save even more lives. Thank you.
Thanks.
Thank you.